get right into these performance measures. All right, so really quick, Sapstar Cadena, I'm going to be the lane into I see for this lane. It's Sapstar and Lopez, secondary grader for this lane. All right, so jump right into it. So if you follow along, apply occlusive dressing is the first step. Okay, so with that, you're going to go ahead and expose the wound. Okay, so you're going to take the tap system off and then expose it, the blouse. You're going to go and open up the blouse. All right, and try and find that wound. Okay, you'll see a gunshot wound. It'll be a little red dot on the lower right quadrant of the rib cage. Okay, that's not going to change. Okay, it's not going to change at all. Lower right portion. All right. Once you've identified your gunshot wound, you're going to go ahead and apply your occlusive dressing, which is a 4x4 strip of lamination paper. All right. Once go ahead and pull your lamination paper out, you're going to prep it. Okay, you're going to wait on the exhale of the patient. That's something that you will have to state, right? Like these casualties aren't breathing, so
he's exhaling.
Apply your occlusive dressing. All right. From there, you're going to log roll your casualty, try and find an exit wound. So again, you'll see a nice little red mark, bottom right portion of that right rib cage. Okay, same steps as before. You're going to wait on the exhale and apply your occlusive dressing.
Exhaling.
All right. Since these occlusive dressings actually stick to the casualty, you don't have to worry about taping all four sides. All right, from there, you're going to go ahead and go into signs and symptoms of tension pneumothorax and identify those, okay? You're at least identifying 3 out of the 7 listed below, okay? So if you look on your EIB book, right under number 2, you'll see A, Alpha, Bravo, Charlie, Delta, Echo, Foxtrot, and Golf, right? You don't need to know all of those. The only ones I recommend are circled here. So Charlie, Foxtrot, and Golf. Learn those 3, those are the easiest ones. For Charlie, all I care about is look for tracheal deviation. Okay? And then just go ahead and circle all of Fox and all of Golf. All right, so it'll sound a lot like this.
I am checking for tracheal deviation.
Your casualty does not have tracheal deviation, but it has mild jugular distension.
I am checking for bluish skin.
Your casualty has mild cyanosis.
I am checking for signs and symptoms of shock.
You observe 2 signs of shock, confusion, and pale skin. From there, you've reached your 3 signs and symptoms of tension pneumothorax, so you're going to go ahead and apply needle decompression, which is the next preventive measure for a chest wound. All right. So from there, you're going to go ahead and locate your insertion site. So that'll be between the 2nd and 3rd rib, intercostal space, midclavicular line, which is generally in line with the nipple. Once you've located your insertion site, you're going to go ahead and sanitize your insertion site, utilizing your 2x2 strip of engineered tape. So that's going to be your cleaning wipe. All right. Where you're going to clean, you're going to start in the middle and work your way out, okay, in a circular motion for 2 to 3 inches around the insertion site. From there, you're going to grab your needle D. Okay. Do not touch that clean site. Okay. Once it's clean, don't touch it. You're going to get your needle, so 14 gauge needle, bevel facing up. Okay, so what I mean by that is that cut-off portion of the needle is going to be facing towards the head, okay? So you're going to take that needle and catheter, face it at a 90-degree angle against the chest, and then start inserting it. Once you start inserting it, we'll state that you feel a pop. From there, you're no longer feeding that catheter down, okay? You're just going to stop movement, okay? You're going to remove the needle off the catheter and place the needle back into its case per unit SOP. Okay, so that's our SOP. You're going to put it right back in and put it to the side. All right, from there, you're going to go ahead and feed your catheter down without kinking it. Okay, you're going to feed it all the way down so that orange portion of the catheter reaches that chest wall. From there, you're going to go ahead and aspirate as much air out of that injured side as possible. Okay, we'll state you've aspirated the chest. Okay, from there, that's your cue to now start working on your one-way flutter valve. So you're going to create this, your flutter valve utilizing a sterile glove, which will be in the IFAC. Okay, you're going to cut off a finger, the full length of the finger, off the glove, and then you're going to cut the fingertip off that glove. Okay, that's going to be your valve. You're going to secure it to your the orange portion of the catheter utilizing tie method, which we have rubber bands, or tape, which is also in your IFAC, or the casualties IFAC. You make me nervous, man.
I'm just here to help.
Oh, okay. Once your one-way flutter valve is secured to the catheter, you're going to state,
I am observing the catheter.
all right,
Or the one-way flutter valve, sorry.
observing the one-way flutter valve. That'll prompt me to come over and check your valve. All right, so I'm going to come over and I'm going to ensure that it's secured to the catheter and that you're not covering the hole on the inside. Okay, does anyone know why we're applying this one-way flutter valve? What's the purpose of this?
Can you see the air move somewhere?
Yes. Okay. Exactly. So as air is being aspirated out of that chest cavity, it's going to go ahead and move that glove back and forth. So you see a visual representation of air leaving the body. And it's also stopping any air coming in. Okay, so essentially if air is trying to come in, it'll just collapse on itself and it won't let anything come in. Okay? Does that clarify that? Okay, so that's your one-way flutter valve. I'll state your flutter valve is working if it's properly secured. And you'll go ahead and secure your catheter flutter valve to the chest. So you'll go and rip off a piece of tape, you'll Y-split it, and you'll go ahead and secure it. Okay. So once your needle D is secured, we're gonna go ahead and start getting vitals, okay? So first you're gonna get your pulse, okay? So you're gonna use you're going to get it on the carotid artery, so that's going to be under the jawline of the patient, right under, okay, right next to your jugular, right, just like that. You're going to go ahead and it's always going to be 60 over palp, okay. If you're getting a vital sign under the jawline on the carotid artery, it's always going to be 60 over palpitation, okay. That's just a hasty version of saying like, okay, I got a pulse, his main vital organs are working, all right, he's stable. For what we have, right? So 60 over palp, that's what you'll annotate. And then you'll get your O2 sensor. So he doesn't even have arms or legs, so the way you're gonna do this is you're gonna clean your own finger, right? Utilizing that same 2x2 strip of engineer tape. You're gonna clean your finger off, ensure that it's dry, and apply your O2 sensor, all right? So our O2 sensor will have vital signs written on the top. Obviously that's not a real O2 sensor, it's just a chip bag clip. Do what you got, right? All right, from there, you're gonna go and pull out your TCCC card. Look like this, front and back, okay? And you'll go and start writing down information that you, as per the EIB book, right? So everything in blue that you see on this the board here is gonna be administrative data, so you don't have to worry about writing that. That'll be already pre-filled out on your card. Everything in red will be things that you have to annotate, all right? So starting from the top, you'll go ahead and mark that he's urgent, all right? So on evac, so you've classified him as urgent, so he needs to get out of here as soon as possible. All right, from there, you're gonna go